Good afternoon or good evening, good morning, wherever you're tuning
Yeah.
in from. It's great to have you all on again for another continuing education webinar through our NSWAC and WAC Institute. And we're so pleased to be completing. We're happy that we've had a fantastic series in partnership with Geko and Perfuse Medtec on wound care strategies for keeping the patient at home and in the community. For those of you who've been attending throughout the entire first 6 months of the year here, we really appreciate you sticking on. We're happy that you made it to our final session. It has been 6 fantastic presentations. Dr. Sibbald, who's with us today, has already done one himself, so we're really happy to be ending it off with such a fantastic presenter. Before I get into Dr. Sibbald's introduction, I'll do a couple housekeeping items. First things first, I can see most people are doing it already, but click on that webinar chat button in your Zoom toolbar and let us know where you're tuning in from today. I think we're going to be doing a couple polls today throughout the duration of the presentation. So while we'll be using the chat for some of the conversation, make sure you are prepared to answer some of the polls as they get launched a little bit later into the presentation. We are also going to be doing a Q&A session at the very end of the presentation. So if you have any questions, we do encourage you to put them in the Q&A button in your Zoom toolbar. So not in the chat, but the Q&A, that'll make it easy for us to keep everything organized and get to as many as we can at the end. We're also going to be recording today's session, so if you have to head out a little bit early, or if you wanted to watch this back again or share it with your colleagues, it will be available on our nswoc.ca website, so no fret there. So without further ado, I'm really excited to be introducing our speaker for today's session on options for prevention and treatment of diabetic foot ulcers, and it's none other than Dr. Gary Sibbald, who is the lead of Project ECHO Ontario Skin and Wound. He's a dermatologist and internist with a special interest in wound care and education. He is a professor of medicine and public health at the University of Toronto, and as a wound care educator, clinician, and clinical researcher, he is also an international wound care key opinion leader. Dr. Sibbald is the co-founder and course director of the International Interprofessional Wound Care course and is the director of the Masters of Science in Community Health, Prevention and Wound Care at the Dalai Lama School of Public Health at the University of Toronto as well. Dr. Sibbald is also the former president of the World Union of Wound Healing Societies from 2008 to 2012, and is a co-editor and chapter author of the Chronic Wound Care textbook. He has over 200 publications and is the current co-author of the journal Advances in Skin and Wound Care, and you might have recently seen him at the NSWAC National Conference this past May. So without further ado, I'm very happy to pass over the mic and the slides to you, Dr. Sibbald. Thanks for being with us today.
Thanks very much, and welcome everybody. And as we're getting ready for the summer break, I've got a lot of co-contributors, and on the next slide, my conflicts of interest are ECHO and the International Interprofessional Wound Care course, and I am co-editor and chief of Advances in Skin and Wound Care, Perfuse Medtec, who's sponsoring this, and chymoseptine for our Philippine type of work. Next one. We're going to reflect on the impact and burden of diabetes, discuss the use of a validated, evidence-based screening tool for persons at risk with the diabetic foot ulcer, and review the importance of wound bed prep 2024 for persons at risk or with a diabetic foot ulcer. Now, next, we want to know who you are. Paraprofessional is often a PSW, different names in different provinces, community health worker, RPN, and vote for the highest one on this list that applies to you. A SWAN, an NSWAC, an MD, an allied health, rehab, OTPT, foot specialist, podiatry, chiropody. So I think the poll is up, and let's get you to vote. Okay, so we have a varied population. We have 56% RNs, 6% SWAN, 8% NSWAC, 3% MD, 3% Allied Health, and we have RPNs at 23%. And we have one paraprofessional. So welcome. Next one. The number of people with diabetes worldwide is staggering, but it's really on the increase. And when we look at the percentage increase in the various countries, you'll see that the developed countries, Europe has a 10% increase predicted between now and 2050. North America has a 21% increase, a little bit more than the Western Pacific at 18%. But then if we look at developing countries, we get 45% for South and Central America. We get 92% for the Middle East and North Africa. And Africa is a great high increase of 142%. So we really need to aim strategies at trying to reduce the incidence of diabetes in the developing countries. And to some extent, that applies here to the north, remote, isolated, and indigenous communities. Next slide. So if we look at this increase, the number of people with diabetes is going to go from 151 million to 589. And when we look at the projections of the prevalence of diabetes in the 20 to 79 year age group, you'll see that there is a marked increase as well. Next one. Okay, here's your second question. Amputation rates in Northern Ontario, Indigenous, remote, isolated communities have been estimated to be 3 times higher than the Greater Toronto, 4 times, 8 times, 12 times, or 16 times. And this is an interesting journey. And maybe in some ways a little bit of a trick question, but I'll be interested in your responses here. So what we see in the responses are that actually a minority of you voted for 3 times, but 3 times higher with 13% actually goes to 39%. So it's really very high. 16 times higher is way above imagination, but yet there are some papers published looking at kidney patients on dialysis with peripheral vascular disease. And in fact, in that small population with many risk factors, it is in northern Manitoba 16 times higher than in the southern part of Manitoba. So that some of these figures, although they appear not to be realistic, are actually happening. Next one. Northern Ontario has 3 times the rate of diabetic foot amputations than the Greater Toronto Area. Next one. And the long-term survival after major lower extremity amputation is low for all people, but even lower for the First Nations. And this is something we need to address, and it may relate to the services post-amputation. Next one. Diabetes Canada shows the incidence of diabetes is increasing. It's anywhere, depending on populations you look at in Canada, 2.5 to 25%. The lifetime risk of an ulcer, 25%. Recurrence within 5 years if you've got a foot ulcer, 50%. Persons with diabetes and non-traumatic amputations, 70%. So this is a population we need to help. We can prevent over 80% of these amputations. Next one. What percentage of lower extremity amputations are preceded by a diabetic foot ulcer? I think this is important to remember as we go into the prevention mode, and it is an important piece to actually put together. And so you can make a difference. And recognizing where you've got a high-risk foot can make a big difference. And here we see we have 16% at 85%, but it in fact is 85%. So how can we do this? Let's look at the next slide. 85% of diabetes-related limb amputations are the result of a non-healing diabetic foot ulcer. Persons with diabetes have a 20 times risk of a lower non-traumatic lower limb amputation. Worldwide lower extremity amputations are anywhere from 25 to 90% diabetic related. In 5 years, 50% are dead or 50% have a second amputation. Those are not good figures. Next one. And here we see, and Andrew, press again, after an amputation, the 5-year mortality is higher than prostate cancer in males, breast cancer in females, Hodgkin's disease, and certainly the neurotrophic ulcer is up there with the amputation. So we need to do better. Next one. Here we see that 43% of amputations occur amongst those with diabetes age 40 to 64. So it's a younger age than a lot of other chronic wounds. And I think this is an important aspect on which we need to focus. So you don't screen just people over 50. You really need to screen back to anybody with diabetes. And with the diagnosis of diabetes, those persons are at a higher risk, and they could very well have had sugar abnormalities for 10 years or longer before the diabetes is diagnosed. Next slide. Every 20 seconds, a lower limb is lost to diabetes. And we're going to show you a simplified, instead of the InLo tool, which is an assessment tool and realistically takes half an hour, we can look at a 60-second screen to save a limb. And this is something you can do in your practice. And we even have a group in Baywating that are doing these screens on a regular basis on every visit of their persons with diabetes, not just the recommended visits. Next one. This is Wound Bed Prep 2024, which we're basing this talk on. And here you see with numbered 1 to 10, it's got icons. It's got ability to heal. Number 3, it's important to determine if it's healable, maintenance, or non-healable. And a maintenance wound and non-healable wound, we want moisture reduction and bacterial reduction. And number 8 is healing rate. If they're not 30% smaller by week 4, they're not going to heal by week 12. And this is where we really need to think about putting other interventions together to make this better. And you can see that hemoglobin A1C and blood pressure are important, as is the VIP, vascular, infection, and pressure. We'll go into each of these in more detail. We're not going to talk about pain, activities of daily living, and support system and medication, but it is important. We well document the local wound care, and we know the 3 components are debridement, infection, inflammation, and we'll come to nerds and stonies in a few minutes. Moisture management and the difference between healable moisture balance and moisture reduction for maintenance and non-healing. The healing trajectory, the edge effect, adjunctive therapies are often saved for patients that are healable but stalled. And healthcare system change. Every time you see a patient with a wound, think of how you can do it better. Next one. Key priorities, the Narayan public health modalities for diabetes control in low-income and middle-income countries. Glycemic control with a hemoglobin A1C less than 9, which is a very conservative one. In Canada, it's recommended to be less than 7, ideally. Blood pressure control in people with diabetes, greater than 130/80. Without diabetes, 140/90. With kidney disease, 120/80. And the Canadian guidelines are modified from the original Narayan was 140/90. Foot care in people with high-risk diabetic feet. And so all of these priorities can improve patient outcome and save healthcare systems money. Next one. So why screening is so important? Group 0, these are patients with no peripheral neuropathy, no peripheral vascular disease, and no other risk factors. Their incidence of an ulcer over the next year would be 2%. In group 1 with peripheral neuropathy, it goes up to 4.5. Group 2, peripheral vascular disease, it goes up to 13.8. Any two of four things, peripheral neuropathy, peripheral vascular disease, the history of an ulcer, or the history of an amputation, it goes up to 32.2%, or 52.7 times more likely to develop an ulcer in the next year. So these are the patients that you need to identify. Next one. Phase 1 of the Guyana Diabetes and Foot Care Project was funded by CIDA, the Canadian International Development Agency, and we did get a renewal for Phase 2, also funded by CIDA. And we regionalized comprehensive diabetic care into 7 satellites, and the lead organization was the Canadian Association of General Surgeon, and this is Guyana, South America, the only English-speaking country in South America. It's just under 1 million people population, and that's very equivalent to a health district in Ontario or districts across the country. Next one. And we developed a simplified InLo tool to focus on prevention. And this has a history, inspection of abnormalities, palpation for pulse, check for deformity, and do a monofilament testing. Next one. Let's listen to the screen and then I'll go through the various sections.
Simplified 2012, 60-second. Have you had a previous ulcer?
No.
Amputation?
No.
On exam, look for deformity, callus, blister, linear crack or fissure. Check the toe-X because there may be a crack or fissure. Look on the dorsal surface, look at the nail folds for any thickening or ingrown nail folds. Then feel or palpate dorsalis pedis, posterior tibial pulse. Do you feel this?
Yes.
Using the monofilament, tell me when you feel it.
Yes. 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 Yes.
2 negatives, we need 4 or more negatives for a positive test. Remember to do the other foot.
Okay, so that was really explained, and we went over the screen completely in less than 60 seconds. Next slide, Andrew. This is the screen, and Hiskey Smart and some others have turned this from portrait to landscape and actually give patients on the far side what they should do in terms of follow-up. Next one. So the first screening thing is if they had a previous ulcer. And here you see a scar. Number 2, a previous amputation. The toes are missing and you see some toes preserved in the final picture there, the third picture. How many of you noticed that in the first picture there's only 4 toes? Next one. Deformity, and you can see various deformities that exist on physical exam, and these people are at higher risk and should be looked at in more detail and have a detailed assessment. Next one. Charcot joint is one of the biggest deformities, and the importance is that the temperature can be greater than 10 degrees Fahrenheit or on an average 8 to 15 degrees Fahrenheit compared to the contralateral foot. Sometimes they're associated with ulcer, but most often they're intact. They're red, and infrared thermometry to measure the temperature, which when active, they should go out of the clinic in a wheelchair. And it is important because otherwise they'll break down all the small bones in the foot and preventable amputation. Next one. This is the ingrown toenail. Often you don't see the distal nail. It's under the nail fold. This is an exaggerated one, but you can see a more subtle one in the second photo there. And this is important to pick up. And this can be the start of an osteomyelitis in the phalangeal bone of the large toe. Next one. Absent dorsalis pedis pulse. And we did demonstrate checking for the dorsalis pedis. About 8% of people have an aberrant pulse. Check the posterior tibial as well. Next one. An active ulcer. And remember, an ulcer is a loss of epidermis with a dermal or deeper base. So that this is important. And the maceration around there tells us that the wound dressing is not controlling all the exudate. And we have to look for other signs of infection. Next one. A blister. And a blister is a fluid-filled type of sac. And less than a centimeter is a vesicle, and greater than a centimeter is a bullae. You see a fissure, and a fissure is a linear crack with a loss of epidermis and a dermal or greater, deeper base. Now, this has been removed from the tool because the fissure is often there's a cut that's often very deep or what looks like a cut, and that may just be intraepidermal, particularly on the heel. So it did not validate in the tool and it was removed. Next one. This is callus, and you see the callus is over the first and fourth metatarsal heads here, and as well as on the side of the foot and on the toes, which obviously are claw toes that then are in contact with the floor and create increased pressure. Next one. Remember to check the fourth and fifth web space because tinea will cause the maceration and the breakdown of the keratin, and then secondary bacteria, staph and strep, can get in there, and with lymphadengitis cause a cellulitis of the lower leg with the retrograde spread. Next one. Here is an important slide. And this was a study looking at a few hundred patients that had higher incidence of gangrene foot ulcers in patients with and without onychomycosis. And here you see that the incidence in this population of gangrene without an onychomycosis, which is a nail fungal infection, onycho is nail and mycosis is fungus. And you'll see that with onychomycosis, the incidence of gangrene went up to 4.8%. With a foot ulcer, without onychomycosis, 2.2%. With onychomycosis, 6.2%. Gangrene plus a foot ulcer doubled. It went from 0.6 to 1.2%. So this is an important thing. And now onychomycosis or fungal nails are considered a high-risk foot. Next one. Here are the 4 patterns of fungal nail infections. The most common is that distal and lateral subungual onychomycosis. And it starts distally. It comes from dry skin on the bottom of the foot and the plantar surface of the toes, then invading the nail. and you see those streaks that are wider distally and more narrow proximately. If you skip over to the whole plate onychomycosis, which is on the right lower, you see destruction of the whole plate. And this is the final stage of a fungal nail infection. Secondary molds may be seen, and one of them is called scapulariopsis, and large toenail infections. You also see the less common forms to the lower left, superficial white onychomycosis, and this is often a yeast type of infection, and this one can sometimes be treated topically, and we have topical modalities that we can use to treat that. One of them is Jubula, and if you go up to the top right, proximal subungual onychogryphosis, or it should be onychomycosis rather. And this involves the matrix or the half moon. When this occurs, we know the patient's immunosuppressed. And there have been some patients with lymphoma or patients with HIV that have been diagnosed just based on that nail change. There are 22 other disorders that can cause nail abnormalities, and they have been divided in this chart into color change, thickened nails, abnormalities of the nail fold, and then looking at the paronychia. And when you take a sample from nail, and usually we want to see a positive KOH, so under the microscope with potassium hydroxide that contains fungal filaments, or you grow the fungus on Sabarose media, which is designed to grow the fungus and not to grow a number of the other modalities. Next slide. Here on the screen are the 10 points that you see me demonstrate. You're going to only use the monofilament and create a half moon and press each one only once. And you should try to change your rhythm, make sure the patient closes their eyes, and you should go up around the knee or around the elbow, because neuropathy is stocking and glove when you're testing them. Do you feel this? And if they say no, you need to go up higher until you get the patient to say yes before you start your foot exam. Next. 3 components to neuropathy: sensory, it's a loss of protective sensation, predisposes to pressure ulceration. Patients are unaware of trauma. And in Guyana, South America, we tested 1,266 in the waiting room of the diabetic clinic, and 9% of them had an ulcer they weren't aware of. They're unaware of burns from hot water. They get an ataxia. They don't know how to or where to put their foot down, and there's an increased risk of falls. Motor creates the structural abnormalities, the claw and hammer toes. Claw has 2 bend, a hammer toe has 1 bent interphalangeal joint. Muscle weakness, shortening of Achilles tendon, flat foot, diminished joint range of motion and tendon reflex, and it alters the pressure points during gait. Autonomic is nerve damage and you have dry skin. And you have to distinguish that from fungus, and the fungus tends to go around the side of the foot. You may see callus, fissures, loss of hair, fungal nails, and decreased joint mobility. Next one. The symptoms are numbness. It feels like a block of wood, pins and needles, electric shock, tingling, bugs crawling. But we often say it's burning, shooting, stabbing, and stinging. And this is neuropathic pain, which is spontaneous pain. And you have to distinguish this from nociceptive pain, which is pain from an injury. And that's best described as like a toothache. Next one. If you have a negative screen, re-examine in a year. A positive screen, you really need to refer to a foot specialist or team for prevention, treatment, and follow-up. And for positive screening, you have a different referral time based on the positive risk factors. Next one. And here you see a very low risk, no loss of protective sensation, no signs of PAD once a year. A low risk or category 1 loss of protective sensation or PAD every 6 to 12 months. Moderate risk loss of protective sensation plus peripheral arterial disease or loss of protective sensation combined with foot deformity or PAD with foot deformity every 3 months. And then the others, loss of protective sensation or PED, and one of the following, a history of a foot ulcer, a lower extremity amputation, end-stage renal disease. Then it's once every 1 to 3 months. Next one. Okay, what did we do in Guyana? We actually set up a diabetic foot clinic. We set up satellite areas. We had doctor, nurse, and allied health working together. We had 15 Guyanese physicians, nurses, and allied health take the International Interprofessional Wound Care course, and we worked on Wound Bed Prep 2026. I'm now showing you the same thing with Wound Bed Prep 2024, which is our 8th edition, and we got a 68% reduction in amputations, and that clinic is still going today. And I think it's something that we can do better. And using this as an example, I think we can model some of the strategies to make things better. Next one. In the wound bed prep paradigm, I am going to go through vascular infection and pressure redistribution. Next one. Even before that, looking at the whole person and not the hole in the person, hemoglobin A1C, it's optimally below 7. And this measures the average blood sugar over 90 days. Blood pressure, I showed you the optimal readings. Cholesterol, you want a low density lipoprotein of less than 2 or a greater than 50% reduction. And drugs to lower cholesterol, you may know them as Crestor or Lipitor, and these are statins. Drugs to protect the heart, and you see here there are a number of them, including the statins and aspirin and the various things to treat diabetes. Exercise and healthy eating, screening for complications, smoking cessation, and self-management, stress and other barriers. And I think here there's a lot of recent diabetic literature around patient empowerment, and that's something you should think about. Next one. So let's look at the vascular infection, pressure downloading, and sharp surgical debridement. Next one. Here we see the prevalence of peripheral arterial disease is increasing in type 2 diabetes patients, 15.2 to 40% compared to the general population, 5 to 5.6%. So it's almost 3 to 8 times. And it increases the risk of a lower extremity amputation 5 times and the probability of mortality at a younger age. Screening, palpating the pulse, the audible handheld Doppler waveforms, I'll show you a little bit more. We prefer this over the ABPI, but the ones that have a monophasic pulse and other signs of peripheral arterial disease, check for dependent rubor. It's red when it's down, white when it's up. It's a cold foot to the touch and decreased circulation time. They need formal vascular studies. Remember, an ABPI can be falsely elevated in patients with diabetes, and you need adequate blood supply necessary prior to sharp debridement. Next. Here's the study we did on 200 consecutive patients in our Mississauga interprofessional clinic. We looked at 379 legs. It doesn't mean that 21 legs had an amputation. There were other factors that limited the testing. And specificity, no peripheral vascular disease, posterior tibial, and it had to be biphasic or triphasic, okay? And a biphasic wave sounds like pshh, pshh, pshh. A triphasic wave sounds like pshh, pshh, pshh. And a monophasic wave is s, s, s. And the sensitivity, the peripheral vascular disease identified is low because you're not going up the leg and checking all this. But this did have a very positive predictive value and a negative predictive value, so that audible handheld Doppler was reliable, simple, rapid, inexpensive bedside exclusion test for peripheral vascular disease in diabetic and non-diabetic subjects. Next slide. Why is it preferable? A proper ABPI, the patient needs to be lying flat. You got to squeeze the calf. Patient can be sitting in a chair. No pain from squeezing the calf, not influenced by a calcific vessel. Any multiphasic wave will result in an AHHD value equivalent to ABPI 0.9 or equal. Monophasic or absent waves should trigger a sequential duplex arterial Doppler in the vascular lab, and 8% of people have an aberrant dorsalis pedis pulse, so you have to check the posterior tibial when you don't feel it. And you can tape this on a smartphone, MB3 or MB4, and send it to somebody for verification. And this could save some flights out of the north, remote and isolated areas. So I think this is something that you should really think about as an important strategy. And we are, through Project geko, whether it's Indigenous Services Canada or ECHO Ontario, giving instructions in how to use the audible Doppler. And we have toolkits with a Doppler infrared thermometer that you can get by attending 6 out of 8 echo sessions and learning how to use it by participating in the 5 to 6 skills exercises. And that's worth over $1,000. Next one. Let's look at infection, nerds and stonies. And we did do a validation to show that the Canadian Tire infrared thermometers used to test motor temperatures and to find hotspots in the walls from electricians really did the same as the Exergen, which is the scientific standard that cost almost 1,000 Canadian dollars. The Canadian Tire thermometers go on sale for $30 to $40. The Exergen cost almost $1,000. The Canadian Tire ones can be a foot away, spot to distance. The Exergen can only be 2 or 3 centimeters. So they're less likely to get contaminated. Next. Here's the NERDS criteria, non-healing. You have an exudate that's increased, red bleeding tissue, debris or smell. Any 3 treat topically. Stonies has exudate and smell. In the side, the size is bigger, but 8 times more likely is an increased temperature compared to a mirror image on the other extremity. Os is Latin for bone. It either probes or exposed. New areas of breakdown, and erythema and edema is known as cellulitis. Increased pain without another reason and in the region of the wound can count instead of one of the clinical signs. Just remember, pain is a symptom, not a sign. Next one. Here you see the NERDS criteria. These are non-healing ulcers. They have increased exudate. Look at the white maceration around some of these, and look at the pyrocinin from Pseudomonas. Once you smelt that, you don't forget it. The red friable tissue is evident, particularly in the middle bottom photograph. Debris is present in the top photograph, and smell usually indicates gram negatives or anaerobes, so the wound's been there for a while. Any 3 we treat topically. Next. Stonies has a size increase, temperature difference of 3 degrees Fahrenheit or higher, the probing to bone. You see the new areas, the satellite areas of breakdown, and you see exudate or pus, and there's pus at the base of that large toenail. And when we released that and removed the toenail, there was exposed bone, and there was osteomyelitis in that toe. Next one. Let's introduce, and this is the continuing education article in January Advances in Skin and Wound Care. And what we did was look at what's called the therapeutic index of topical antiseptics. And this was stimulated by the great late Dr. Gregory Schultz, who was a professor in Florida and really had an expertise in wound infection. Next one. Chronic wounds have a bacterial bioburden, and the major colonizing organisms are Staph, Strep, Pseudomonas. We have biofilms, which are hard to measure in this, and E. coli often can be a secondary passenger. Next one. So the therapeutic index measures the mean cytotoxic concentration in mammalian cells, and to get an antiseptic property on a product, you need to measure this over the mean bactericidal concentration of the bacterial species to that antiseptic. And the higher the number, the less toxic it is to the mammalian cells, and the more effective it is for bacterial species. Next one. So we looked at a number of topical antiseptics, a number of organisms. We couldn't, because of spreading factor, look at Streptococcus. In mammalian cells, either the fibroblast or the keratinocyte in humans or the mouse fibroblast. Next. Oh, the results are up. There goes a question. Hypochlorous acid had the highest therapeutic index for E. coli, Pseudomonas, and Staph aureus. PHMB had the highest therapeutic index for MRSA, 12.1, and this is very good. But on the next slide, this is really only one factor. And if bacterial killing is more important than cellular toxicity, then things like povidone, etc., become your treatment of choice. And you want a balance between killing bacteria and harming wound cells. And once you get rid of the 3 NERDS criteria, then you need to move away from the antiseptic and into moisture balance. But antiseptic choice should be individualized to the patient. Some may sting one patient and not another. Others may not be as effective in one patient as another, and there may be other factors. Next one. Here it is, 2 surfaces of different viscosity favor biofilms. Above the wound, saline and potable water can be used if you're in bacterial balance. If you're not, hypochlorous acid, acetic acid, PHMB, chlorhexidine. We tend to use povidone iodine in packing so that it covers the surface compartment as well as the above the wound compartment. We don't use it as an antiseptic cleanser or a soak or compress as much. And here you see the NERDS on the surface, and here you see some of the modalities you can choose. Remember that methylene blue and gentian violet foam, you may know that as Hydrofera Blue Ready or Hydrofera Blue Classic. The modality along with PHMB, whether it's the gauze or the foam, stays within the modality. For chlorhexidine, your chlorhexidine in Bactigrat stays in the Bactigrat. Silver often donates to the wound, as does iodine. Iodine is pro-inflammatory, silver is anti-inflammatory. Iodine, because it's a small molecule, penetrates the glycocalyx of a biofilm better than silver. On the stony size, you see the criteria there, and that's the deep and surrounding. You have to remember it comes up the side of the wound as well. And from the Oviva study in the New England Journal in 2019, oral or systemic antimicrobials did very well and were equivalent. And so for some of the northern remote and isolated communities, we will be probably using sometimes a higher dose of oral modalities. Next slide. So the role of the infrared thermometer is an early warning stage of a Charcot foot, but it's also something that we use in infection. Next one. What's offloading? It's redistributing a localized area of pressure to the broader area of the plantar surface or even up the leg. And they are not equal in pressure redistribution, healing times, cost, or patient acceptability. Next one. And it depends, non-removable knee-high offloading device. The total contact cast is the gold standard, and it is non-removable. It may have a window. The removable cast walker can be made irremovable and can be equivalent to a total contact cast. But you need resources, technician skills, patient preference. They may not be able to drive a car. The foot deformity may be too great to accommodate these. And if you've got active infection or ischemia, not a good idea. Next one. So there's the two contact cast, or we may use something as simple as a Darko boot. And this was used in the Guyana project, and really it's plastisoporon or felt or foam as an insert rather than a much more expensive orthotic. Next. Here's a case just to finish off. Next one. Here's a patient I saw in September of 2023 with allodynia, pain so bad that you couldn't touch his neuropathic foot. He jumped off the exam table. Next. He's a male, 70 to 79, Caucasian, partnered, urban setting, retired, peripheral vascular disease, congestive failure, chronic anemia, alcoholic-related hepatitis 12 years ago, surgical history of bilateral femoral artery stents, and no allergies, substance use, smoked for 50 years, for 75 pack years, and stopped in August of 2023. Home nursing care wasn't getting anywhere, and he was advised to have an amputation. First saw him in September of 2023 following a femoral artery stent with necrotic wounds, and it may take a month or two for reperfusion injury to finish. Pain was off the map, sleeping, sitting on a couch. First visit, we changed saline to hypochlorous acid. We treated him with the geko device, which is a neuromuscular stimulator, which causes a twitch in the foot, increases circulation almost fourfold with the flush. The nitro patch was used for the 12 hours the geko was off. Next one. And when we saw, I did use EMLA, which is eutectic mixture of local anesthetics and an injection to remove debris. And there was actually pus under that necrotic hub on the fourth toe. And you have to do conservative removal. If you do acute surgical debridement, he needs even more blood supply, which he doesn't have. January 2024, pain after walking. Only the fourth toe was involved by this stage. By March of 2021, the bone was exposed. He had a monophasic pulse still. He was restarted on moxiflox, and we used betadine between and inidine on the proximal area of necrosis. Next one. November 26, 24, finished geko. Home nursing care was stopped. Pain was symptomatic. Sometimes 8 out of 10. Right now, it's 1 or 2 out of 10. No visible or open areas on the right foot. The fourth toe had healed, and there was no probing to bone. You'll see he's got tubic grip on or very minimal compression. Next one. All right, we're done. And what I will say is that the International Interprofessional Wound Care course is to train key opinion leaders. The 50th course worldwide. It is a certificate of completion. It's also a master's course at the University of Toronto. And the course in September 18th to 20th, for those of you who are interested, there will be a number of scholarships, etc., available. Next one. And the next echo cohorts on limb preservation, September 3rd, October 2nd. And you can see the topics in this, and this is leg and foot ulcer expertise, case studies. We encourage doctor, nurse, and allied health to attend. It is free to anybody in Ontario. Indigenous echo will be sponsored by Canada. They will be free to people across the country. Our echo in Ontario runs Wednesdays from 1 to 3. The Indigenous echo runs 2 Monday nights a month from 7 to 8:30. So we hope to see you at some of these sessions. Next one. This is their certificate of completion that combines IIWCC, the skills sessions, to learn how to use the toolkit, the 2 echo cycles, leg and pressure, and 4 methods of evaluation. And this is an interprofessional collaborative model, education and situational learning with case studies. And there are sessional fees are what we are seeking for interprofessional care, so that it would make it feasible for you to do this within Ontario and beyond. Okay, and I am now back to any questions from the chat and any other interactive activities.
Awesome. Well, thank you so much, Dr. Sibbald. I'm just echoing what we see in the chat here. Thank yous all over the place here for a fantastic presentation. We do have some good questions here, so we'll see if we can get to as many as we can here. I know we started just a little bit late, so maybe we'll go just past the hour if we have some good ones still here. One of the questions we had coming up here was, during a diabetic foot assessment, how should we interpret and score areas where monofilament sensation is reduced but not entirely absent?
It still means that it's positive, and sometimes it's reduced because of the thickness of the skin, and it may be the way the monofilament hits the skin. But you can mark down, I mean, you only count the ones that are absent. If you have a callus in an area where you should test, you should go beside the callus to do the monofilament testing on what is, closest to what's on the rest of the plantar surface. So, and it's 4 or more negatives that make a positive test. And if somebody had a lot of those iffy ones, I wouldn't wait a year. I would probably test it in 6 months.
Perfect. Well, thank you for touching on that. When a patient with a diabetic foot ulcer also has underlying osteomyelitis, but it's being adequately treated, how would you still apply the 4-week 30% wound size reduction benchmark to assess healability?
I think that what you would look at in healability is not necessarily ulcer healing and being 30% smaller, but I would look for coverage of the bone and make sure that the bone is not gritty. If the bone is gritty, using a curette and sending some of that gritty bone for culture might be very important. You like to feel smooth bone, and sometimes you even have to scarify the bone to get the granulation tissue to grow over the bone so that you're increasing the blood supply on the bone itself. But take a follow-up culture. You should also look at the ESR and C-reactive protein. And these are simple tests. The C-reactive protein is often normal is up to 5. It's often 50 to 60. The ESR in an active osteomyelitis might be even higher than that, and it might be as high as 100. And you look for these coming down along with the clinical signs of stonies. And so I wouldn't say that once you've got a deep ulcer, you're really looking at the depth decreasing, and you're looking initially at covering the bone with granulation tissue. And a glove finger is much better than putting a cotton tip applicator in to judge that.
Yeah, well, thank you for touching that. I know we always get a question about osteomyelitis when we talk about DFUs here. Next question we had was going back to the diabetic foot assessment. How should we interpret, and oh, sorry, we already talked about that one here. Let's do this one here. In the assessment process, would you consider muscle cramps at night anywhere in the leg to be considered a risk factor?
Not necessarily, because the muscle cramps could just be a nerve compression, like the lateral cutaneous nerve of the thigh, etc. So, and it might be a metabolic thing separate from the diabetes. So I think that's got to be worked up. But claudication, cramps in the muscles on walking, is probably more reliable. But you are right that muscle cramps at night, and sometimes something as simple as quinine will solve that, means that gravity isn't helping the circulation locally, but there can be metabolic and can be structural reasons and positional reasons and food reasons for that. So I think you've got to look at maybe claudication, but you've really got to look at the arterial assessment and think of the audible handheld Doppler or the ABPI or a palpable pulse combined with, is the foot cold? Is there dependent rubor? What about the circulation time? Hair and nails are not really that reliable.
Well, thank you for touching that. I'll just, I know we got a question here that came up about accessing the recordings from previous parts of this webinar series. Just a reminder that it is on the nswoc.ca website. There's a webinars tab, and we'll send that link to you when you get your certificate of attendance as well. That'll be with today's recording too. And going back over to the questions here, we know that hemoglobin A1C is important, but when using insulin to lower hemoglobin A1C, how do we address the risk of insulin toxicity, or what role does insulin toxicity play? How can it be better managed or reduced?
Usually people are on more than just insulin. And I think that you don't want to bombard them with too much insulin. And I think this is where the interprofessional team comes in. And often patients aren't just on insulin, they're on other medications as well. So an endocrinologist or a family doctor who's well familiar with the diabetic control modalities and looking at the classes of drugs and balancing the long with the short-acting insulin. Often patients are started with short-acting insulin and then gradually move to long-acting insulin, with short-acting insulin, if somebody's got a cutaneous monitor, used when the blood sugar is out of whack.
Thank you for touching on that. And just bringing it back here, because I know we've been talking lots about geko throughout this series as well. Did you want to just expand a little bit more about what or when the role of geko comes in helping with diabetic foot ulcers?
Okay. The random control trial was done in venous leg ulcers, and a healable ulcer that stalled would be an indication for geko. And in the Harding series, they used compression on all. At week 4, if they weren't healing as expected, they were randomized to the geko or to compression alone. And the geko, the healing rates doubled, and they continued even after the 4 weeks of geko. Because it causes a flush and increased circulation in the foot in people with borderline circulation, once you've corrected everything else, the geko may indeed help increase that circulation for healing. And we need more circulation for healing. but you've got to control infection. You've got to get the plantar pressure redistribution. You've got to make sure the vascular supply is at least adequate. And we did heal our patient with a monophasic pulse, but we were optimizing everything else from pain control to antibiotics and antibacterial agents, the local wound care, the conservative debridement, the keeping the extremity warm, the patient monitoring insulin and the other drugs. But I think, you know, for us to delve into the insulin toxicity and to delve into all of these other things, we really need a team that can consult with us and better to manage the patient, even if that team is remote. And I think ECHO and NSWAC looking at mentors to people taking the indigenous ECHO. We hope to build these teams and build these consultative arrangements as best we can.
Thank you for touching on that. I'm hoping we can maybe just get to one or two more questions here really quickly. I know we've got some good ones coming in here. This we'll talk about quickly here on fungal toenails here on fungal nail infections. One question is, if a patient has both calluses and fungal nail infections but maintains good protective sensation, how should we assess the risk and what would be the most appropriate management or preventive strategies?
Okay. The fungus, first of all, you should confirm that it's fungus. And, you know, we either take a scraping from the foot or we take a clipping from the nail. But it's the abnormal nail that increases the risk. But the very most important thing is to look in the fourth and fifth toe web. And if the skin's macerated, then that has the setting and it's moist then. That has the setting for staph and strep to get into the lymphatics and spread proximally to cause a cellulitis that can be limb and even life-threatening. And if you see that, povidone iodine, and patients can buy 100 mils at a pharmacy for under $10, and using a cotton tip applicator after bath and showers, making sure the area is dry, and putting it between all the toe webs. But the fourth and fifth is always the first one involved and probably the one that causes the proximal infection the most. And that's the biggest risk. Using an antifungal cream, any cream that ends in azole, azole, clotrimazole, miconazole, econazole, etc., ketoconazole, can be purchased over the counter. And patients should use that daily or twice a day when the fungus infection's there. Lamisil or terbinafine can be obtained on a prescription. It's Cidal, a little bit more effective. Important, when the fungus goes away, recurrences are common, so using the cream twice a week and a good moisturizer, either a lubricating or a humectant moisturizer. Humectants bind water, urea, lactic acid, maybe ceramides and glycerin.
Thank you for touching on that. And I'm going to say thank you to Ravi in the chat who shared some, it looks like a good video on talking about Charcot foot limb salvage with insulin resistance improvement. So talking about the insulin toxicity improvement. So that's great for anyone who's interested in that and wants to take a quick look. Thanks for sharing that, Ravi. And I know that we've got Jeff Forney here from Perfuse Medtec, who just, I see you're popped on there. Did you want to make any comments there, Jeff?
No, just before we go, I just wanted to cheer on the Edmonton Oilers. They actually use our product for muscle recovery, but unfortunately, so do the Panthers. So
maybe that shipment could have got lost, Jeff.
Well, you know, every team that made it into the playoffs actually uses our product. So, you know, I think we can take pride in that. It's you know, it's not just medicine that we address, but at any rate, Gary, I know you're a huge sports fan, and even the professional women's hockey league is using the product now. So
yeah, that's
fantastic.
Pretty good stuff. Well,
yeah.
You know, the other thing, Jeff, the only saving grace for the Panthers is their coach is a native of Sault Ste. Marie.
There you go.
But I still want Edmonton to win.
Well, the only other saving grace is that there's only 5 Americans on their team, right?
There you go.
And the ones that are bringing us the most grief are Canadians, like
Yeah, I know,
Marshawn
that's
and
a
Bennett, you
problem.
know. So
Mhm.
at any rate, you know, I hope the Oilers win, but even if they don't, Canada still wins because it's all our players, right?
Absolutely. Well, I want to say thank you again to you, Jeff. You've been such a huge supporter of this webinar series, of course, on behalf of Perfuse Medtec and of course geko, the product we were mentioning there too. For anyone who is interested, and I know I mentioned it before, but this is the 6th of 6 parts on wound care strategies for keeping the patient at home and in the community. So while we talked about diabetic foot ulcers today, we've talked about venous leg ulcers, peripheral arterial disease. We've gone through quite a few different fantastic wound care topics here. So I do encourage you to go check that out. We're going to share the link to watch those after the fact in the certificate of attendance email you're going to be getting. So do stay tuned for that. It'll just take a day or two to get in your inboxes. But we do encourage you, if you haven't already seen it, please go back and watch those. It's a fantastic series. And as we mentioned before, Dr. Sibbald was one of the presenters on a different webinar, a part of that series. We also had Dr. Michael Stacey and Dr. Robyn Evans as well. So just wanted to put that out there as we close up this the series.
Troy, could I just add that we have a series planned for the fall and for the spring of next year as well. So you know, continue to stay tuned. I think the educational quality has been extraordinary. I truly appreciate the presenters. They've done a great job, and thank you so much, and have a great summer.
Thanks so much, everyone. Appreciate you coming on. And as Jeff said, we'll be having some more webinars. There's still a couple more before we hit the summer here, and then we'll be coming right back into the full swing of things in September. So take a look at the website link there, and we look forward to seeing you on the next time. Thanks again, Dr. Sibbald.
You're welcome. Take care.
Good night, everyone.
Yeah. Cheers. Take care. Bye-bye.